Welcome again to Senior Matters. Today our topic is about geriatric psychiatry. Geriatric psychiatry is a subspecialty of psychiatry dealing with the study, prevention, and treatment of mental disorders in humans with old age. As the population ages, particularly in developing countries, this field is becoming more needed. The diagnosis, treatment, and management of dementia and depressions are two areas of this field. Geriatric psychiatry is an official subspecialty in psychiatry with a defined curriculum of study and our core competencies. The rise in numbers of older people with mental health disorders or problems has necessitated the development of the specialty of psychiatry of the elderly. The emergence of the specialty of psychiatry of the elderly has helped to raise the status of this vulnerable group and has also fostered research which offers hope for better treatment and outlook and provides the forward training students in all health and social care and all other related disciplines. This summary of the scope of psychiatry of the elderly is intended to promote awareness of health problems in older people, to initiate or improve the provision of services, and to encourage teaching and research in the area. Today we're very lucky to have one of the expert doctor that will discuss to us about geriatric psychiatry. He is the medical director of Rehabilitation Nursing Center at Everett, and he is also the director of the geriatric psychiatry for Cambridge Health Alliance. Please welcome Dr. Jason Strauss. Hello, Doc. Good morning.
Hi, good morning, Rudy. Really happy to be here.
Welcome to the show. So, Doc, what is a geri-psych and what involves with this field?
So, geriatric psychiatry, as you said, is a subspecialty of psychiatry that mostly involves the psychiatric care of older adults. And this could include people who didn't have any history of psychiatric illness and then once they get older develop depressive symptoms due to different losses or changes in their lives. It could be related to dementia or what our DSM-5 criteria now calls major neurocognitive disorder, so cognitive problems as well as behavioral and mood symptoms stemming from that. Just as well as older adults who have more medical problems and the psychiatric complications that come from these medical issues. And so it is a unique subspecialty of psychiatry that does require its own training and expertise.
So in your own experience, what are the most common diagnoses you've experienced or treated in this field?
Really, the most common diagnoses in this field would be number one, depression. Major depressive disorder and other depressive disorders are very common throughout our population. It's about as common in older adults as it is in younger adults. I'd say about 10% of the population has some kind of depressive symptom, and certainly it can range in severity. And again, these are people who may have been depressed all of their lives, and as they get older, they just have recurrences of the symptoms, or it could be people who didn't have a history of depression, and because of changes in their lives or losses or bereavement, may develop depressive symptoms.
And a lot of people are actually confused between anxiety and depression. Can you tell us what's the difference between anxiety and depression?
Sure. So really, I think the simplest way to differentiate between the two is to say that anxiety is more anticipatory. So people are anxious about something they think may happen, something bad that they think may happen. Depression is more of a responsive symptom. So people become depressed about something bad that has happened or that they have perceived as happening. And so really those are the differences. They're physiologically actually a lot of similarities, and the parts of the brain and the chemicals in the brain called neurotransmitters that are implicated in anxiety and depression are actually pretty similar, and a lot of the treatments of anxiety and depression are pretty similar.
Very well said. And we heard about the terms schizophrenia and bipolar as well. And I believe those are the cases that involve with like geriatric as well. And a lot of people have misconception between these two diagnoses. And can you give us a little definition or differentiation between these two items, schizophrenia and bipolar?
Sure. So schizophrenia and bipolar disorder are both very severe psychiatric disorders that are actually, for the first time, becoming prevalent in a geriatric population. And this is happening because actually the average life expectancy of somebody with schizophrenia or bipolar disorder was actually quite young a generation ago. People are very lucky to live into their 50s, and now they're much more commonly living into their 60s and 70s. So we are seeing both of these diagnoses much more commonly in older adults. So to put it most simply, schizophrenia is a disorder of reality testing. So people do not have a sense of what reality is, and it can manifest itself with different symptoms, things like hallucinations, which are perceptual disturbances, either hearing voices or seeing things that aren't there, or smelling things that aren't there. Another hallmark symptom is a delusional thought. So delusional thoughts are beliefs that are not based in reality, like paranoid thoughts, believing that people are trying to hurt you when that's not the case, or believing that you have some kind of superpower that you don't have. So that's schizophrenia. Bipolar disorder is more of a mood disorder that consists of depression, which you talked about before, and also mania. And so people who are manic, they don't need to sleep, their thoughts are racing, they do things that would be considered risky, like spending all their money or engaging in other unsafe behaviors. So both of these are very challenging disorders that require extensive treatment by a psychiatrist. So schizophrenia is more of a disorder of reality testing, and bipolar disorder is more of a disorder of mood symptoms.
I've read some research that when you get, as you get older, and that delirium is one of the most common symptoms of elderly population. And I know a lot of families don't even realize what is delirium really. So maybe you can shed light to us what is delirium and what really the cause of this, and can we prevent this?
Yes. So that's a great question, and really the issue of delirium is really one of the most important ones in all of geriatrics, and certainly geriatric psychiatry is part of that. So part of what we do in geriatric psychiatry that differentiates ourselves from other fields of psychiatry is that we have so much overlap with medical illnesses. And so a delirium is an acute change in someone's mental status, which is characterized by someone not being able to pay attention, someone's mental status changing a great deal from being sedated to potentially very agitated in a very short period of time. There are many causes, many of which are medical, things like an infection, like someone could have a urinary tract infection or pneumonia. Someone could become dehydrated, but other causes, may be a little bit easier to address. It may be due to a recent medication change, and so addressing that might be an issue. But also, things that are even more easily fixable, like sensory deprivation. So if someone's in a new environment, if there's not a lot of light, if they're having a hard time hearing, due to new onset hearing loss, those are the sorts of things that can actually cause delirium as well. So, really, if there's an acute change in someone's mental status, I think it's, it's extremely important to look at all these things.
We mentioned about depression. Is there any risk involved for those people that has depression and are living in the community? And what is the best way to deal with these people while having depression episodes while in the community?
Yeah, so really one of the biggest public health crises, that we have in this country, but really throughout the world, is untreated and undertreated depression. Again, it's an extremely common illness. Like I said, at least in this country, about 10%, of the population, and the number really is slowly increasing, have some kind of significant depressive disorder. A vast majority of these people are still going around not being treated or being sort of not optimally treated. Maybe they'll see a primary care doctor, which is certainly much better than someone not being treated at all. But it's actually pretty rare for somebody to have treatment from a specialist, from a psychiatrist. I think the most important thing that we can all do is just listen and pay attention. I think paying attention to loved ones who don't seem like themselves. Common symptoms of depression include not being interested in activities that people previously liked, having a hard time sleeping, not, just almost looking lethargic, like, you really don't want to do anything, feeling like you don't want to eat. Again, if someone just really doesn't seem like themselves, I think just the most important thing is to pay attention, show that you care. Show that you want to be helpful, and make a recommendation that they get some sort of treatment for depression.
Yeah, I truly believe that family support is very important for people with mental health disorders, especially in the community. And it's just so sad sometimes to think that geriatrics with mental health become a stigma or have negative connotations in the community. And what is your opinion as an expert to this? And if you hear a statement like this, it's negative about elderly with mental health, and what is your feeling when you hear something like this?
Yeah, I think as a society, I think slowly mental illness is becoming less stigmatized. I think that's certainly the case, with younger generations. I still think with, some of the older generations, who live most of their lives with, frankly, mental health issues being stigmatized, I think it is still hard, for a lot of older adults, to admit that they have depression, they have anxiety, they have some sort of mental health issue, and I think that they're worried about being a burden to their families. I think that's sort of one of the main reasons, that I'm given, that I don't, that I don't want my, son or daughter to worry about me, and they want to be seen in a certain way, I think it's just that it's extremely important for family members to be involved, again, to notice when there's a change, acknowledge it, be willing to talk about it, and I think just encourage them to get help, because really untreated depression is associated with an increase in medical symptoms. It's associated with increased risk for developing dementia, major neurocognitive disorder, and it's associated with mortality.
Yeah, do we have any community resources or any support group that would help the family or the patient itself in dealing with their emotions of having mental health, and any support group in the family that's welcoming, or any like social, civic, or any non-profit organization that would support this kind of family issues and mental health problems?
Sure. So I think the best example of this for caregivers and family members of people who have Alzheimer's disease, which is a form of dementia, a form of major neurocognitive disorder. The Alzheimer's Association, all throughout the state of Massachusetts, really everywhere, they have wonderful resources for families, for caregivers. And again, I've spoken extensively with family members who've attended these groups, and it's really eye-opening, and it's such a relief, for them to encounter people who are experiencing, similar issues that they are, and they're able to get good advice, they're able to get support. It's something that really prevents them from, becoming, from feeling alone. So, and again, even if there's another type of neurocognitive disorder, if someone has vascular dementia, if somebody has Lewy body, these are just other types of dementias. The Alzheimer's Association also has wonderful supports for these people as well. For family members of people who are suffering from, say, depression or bipolar disorder or schizophrenia, the best resource, I would say, is NAMI, the National Alliance for Mental Illness. And they have a wonderful support network for people with mental illness as well as families, to really help in both. If you go to either of their websites, I think just aa.org and I think nami.org. You'll get wonderful information about both.
Yeah, I think Alzheimer's Association on a yearly basis, they do Alzheimer's Walk. And I've been into that several walk with them, and there's a lot of thousands of people attend, and you can see the support of the family, healthcare providers, even non-healthcare providers was in the walk, just to provide awareness that Alzheimer's should not be stigmatized, and these are the kind of issues that we need to support, especially with the family members dealing with this kind of issues with the population. And we discussed about geriatric as well. I know that there is an inpatient, a long-term or outpatient geriatric. Can you give us a little difference between the long-term geriatric and inpatient and outpatient services, geriatric?
Yeah, sure. So, at this point, I work in all these settings, so I can, give you, a bit of an overview. Vast majority of people who have depression, who have dementia, major neurocognitive disorder, bipolar disorder, schizophrenia are certainly seen on an outpatient basis. And so there are many psychiatrists and fewer geriatric psychiatrists in the community who would be able to take care of these people. Usually in an office setting, and occasionally in certain certain hospitals and behavioral health centers, have resources to allow providers to go to people's homes, to go to people's residences, to see them, although unfortunately it's not that common. If somebody, again, regardless of the illness, becomes acutely much worse, someone who's depressed, if they have suicidal thoughts of wanting to harm themselves, or if they have thoughts, of wanting to harm somebody else, or, if they somehow, present a risk of harm to themselves or other people in the community, then there's the option of them going to an inpatient psychiatric unit. Now, older adults with a lot of medical issues, adults with cognitive issues are generally best served on a geriatric psychiatry unit. I work on one over at CHA Everett Hospital, which is just down the road from Everett Nursing and Rehabilitation Center. It's a short-term stay, and what we do, we get people better, we get them on the right medications, we make sure there's not anything medical that's contributing to what's going on, and we make sure that they have support and resources in the community that can take care of them. And there's also, again at Everett Nursing and Rehab, we're long-term care, we do short-term and long-term care. And so the short-term people are people who again are still trying to get stronger, trying to do what they need to do from a therapeutic perspective to return home or to return to the community more independently. Older adults who have major neurocognitive disorders, really have functional issues that prevent them from living more independently. These are the people who live in long-term skilled nursing facilities.
And I know you as a director, medical director for Rehab and Nursing Center of Everett. And what are the services that this center offering to this kind of population, and what are the other clinical teams involved with this care? Sure.
So we're a bit unusual for a nursing facility in that we treat a lot of older adults with chronic mental health issues. We have a lot of patients who have diagnoses of schizophrenia or bipolar disorder or schizoaffective disorder, which is sort of a combination of schizophrenia and bipolar disorder or severe depression. And so it's very important for them to get extensive psychiatric care. And so that's why it's unusual as a psychiatrist that I be the medical director of a facility, but given the nature of a lot of the diagnoses, I think it makes sense. And so, they just, they require a lot of support. They require, observation, close monitoring of their medications to make sure that, they're on a therapeutic dose, and to make sure they're not on too little, to, certainly make sure they're not on too much, to make sure it's not interacting with the other medications that they may be taking, to make sure it's not making them too sleepy. But we also, have a lot of people in our population who are, cognitively, quite intact, have a lot to say and a lot to offer. And so we do work closely with psychotherapists. And so we want to make sure that, as many of our the residents as possible can be seen by psychotherapists, to just for support, to talk about, how to cope with some of the changes that they've been experiencing in their lives. And those are the main things that we offer, and we work very, very closely with the medical practitioners again to make sure that the medications are the right.
Of course, the facility has nursing team that involved with the care, rehab, PT, OT, and speech involved with him. Social worker as well is involved with the team as well. What you mentioned those inpatient, outpatient, and long-term psych services. Which one is most cost effective?
Yeah, I think, without question, the most cost-effective is, keeping someone, on an outpatient clinical basis as much as possible. Hospitalization, is very expensive. Long-term care is very expensive, and so I think that anything that we can do to maximize outpatient resources to make sure that we're giving as much of the care as we can on an outpatient basis. Is certainly a very positive thing. And I think we're moving toward this to some extent. I mean, at Cambridge Health Alliance and a lot of other facilities have, a very integrated team between behavioral health and primary care. At CHA we also have a house calls program, which is geriatric medicine, going into people's homes, and we have psychiatry that is very much part of that as well. Yeah, if there's a way that we can keep people living safely in the community, it's cost effective, but it's also really best for patient care, because almost anyone given the choice would rather be at home, would rather be as independent as possible, would rather have some semblance of what is what they consider to be a regular life. Living at home compared with other options.
You mentioned about medication management, and as we all know that one of the main part of treatment for this mental health population are medication management. And how do you select or decide to what extent you will treat the patient with medications?
Right. This is a very complicated issue, especially in nursing facilities. And so I think just really a lot of it depends on the diagnosis. And so I think if you're treating someone who clearly has depression, if clearly has bipolar disorder, clearly has schizophrenia, there are many evidence-based treatments for these disorders. And so you want to make sure that you give them the lowest effective dose of one of these evidence-based treatments. And again, evidence-based in younger adults, but also evidence-based in older adults. And we know, often older adults require less medication than younger adults. We want to keep in mind, we want to make sure they don't interact with some of the other medicines that they're on. We want to monitor, blood work, labs very closely, and just interact very, very closely with primary care teams. I think that when you're talking about people who primarily have cognitive disorders, so dementia, major neurocognitive disorder, I think you want to be much more careful about prescribing medications to this population, because especially for the behavioral symptoms, which is a major reason why I would get involved, there's not great evidence that shows that medications are helpful, and there's much more evidence that show that these medicines have potential side effects. So we just want to be very careful with that. And so, if someone's experiencing, a cognitive change, we really want to find out why. So is this a delirium? And again, is this something that can be changed or, improved by just changing environment, by giving someone eyeglasses, by giving somebody a hearing aid? Are they on too much of a medicine? Can we just lower the dose of a medicine? Is there a medical issue that's not being treated? Is their sleep-wake cycle off? And we also, and again, I'm glad that you mentioned, our close involvement with nursing and social work and, physical therapy, because, we're a multidisciplinary team, and they are on the front lines and, really, have their, eyes on what's happening, and they can really tell me what are the specific symptoms that are going on, and sort of based on that, we can come up with behavioral plans to help, manage certain behaviors, and even things like music, even things like groups, participating in enjoyable activities, exercise. These are all things that are probably more effective in addressing behavioral manifestations of cognitive disorders than medications are.
You mentioned side effects of antipsychotic medications. So what are the common short-term and long-term side effects of these medications?
Sure. So, these are medications that are extremely effective, in treating psychosis and treating mood symptoms in a lot of cases, but certainly they do have a lot of side effects. And so they can range from sedation, being sleepy, to difficulty walking, to stiffness and tremor. Some of the newer antipsychotics have been associated with increased risk of falls, with increased risk of what's called metabolic syndrome, weight gain, diabetes, high blood pressure. They're associated with increased risk of stroke, increased risk of cardiac arrhythmias. So these are very significant side effects. Again, if you look at the pure numbers, they're still not very high, and I think in a lot of cases, I think with a lot of thoughtfulness about it, you always want to weigh the benefits versus the risks. If somebody is in a lot of distress, and if somebody's symptoms, if someone's truly psychotic and they're going to be in a lot less distress because they're on an antipsychotic, I think you can make the argument that the benefits outweigh the risks. But you have to be very careful and very clear about what you're prescribing these medicines for. If you're prescribing it for something that it's probably not going to work for, that there's no indication for, then often the risks are not going to be worth any potential benefits.
I'm sure your life as a psych doctor is very interesting on a daily basis, and you met a lot of crisis situation in the hospital, whether in nursing home or outpatient services. And so how do you handle this situation, like a crisis situation? Example, violent patients towards you or towards other staff. Yeah. So how do you handle the situation?
Sure. First and foremost, keeping yourself and everyone around you safe. If you feel acutely unsafe, certainly, get the police or whatever authorities involved, and again, make sure everyone else in the area, is safe. That's sort of the most important thing. I think somebody who is becoming violent or that upset, obviously they're clearly, very angry or very scared about something, and so the worst thing that you can do is match that emotion with your emotion. So
Correct.
Staying as calm as possible, is extremely important, and just trying to, really trying to see what's going on. I mean, where I work, I know most of my patients pretty well, and so I try to find out, did something happen? Are they not feeling well? Do they have a difficult interaction with somebody? What is causing them to act this
Right.
way? And is there a way that I can talk to them and de-escalate the situation, or do they have a good rapport with a certain nurse or social worker or therapist? And is there somebody who would be able to talk with them? I think if somebody clearly presents an imminent risk of harm, I mean, certainly, again, get the police involved. I mean, they probably will need to go to the hospital on an involuntary basis if they won't, agree to go. And this is a potential situation where you might want to, acutely medicate somebody if they're putting themselves and other people at risk.
So let's go back to antipsychotic medications. I know I've been a nurse, even in nursing for the longest time as well, about the CMS regulation that only a certain percentage is allowed for antipsychotic medications in a nursing home, or else the quality criteria will drop in a particular facility. So as much as possible, the nursing home would love to maintain or at a lower level of percentage of antipsychotic medication. So what is your idea about this? Do you think this is fair? What do you think, what if the facility is a lot of psych patients and they still want to control the level of medication they give to the patients?
I mean, I think unfortunately, again, I want to say, I think that what CMS is trying to do is very well intentioned, and I think we all share, without question, I want to make sure that people who don't need to be on antipsychotic medicines are not on them, and that's certainly the purpose of the regulations, and I completely understand. And they do. There is some differentiation between people who are taking these medicines with the primary diagnosis of dementia with behavioral issues versus somebody who primarily has schizophrenia or bipolar disorder or something like that, something that there is an FDA indication for these medications. I think, though, this is a distinction that a lot of places, a lot of facilities have a hard time making, and I think that it ultimately will make a lot of nursing facilities think twice about taking patients who have chronic mental illness. And again, we're seeing more and more of these people, like I said before, more people in their 50s, 60s, 70s with schizophrenia, bipolar disorder, who are now living to be older because of overall better medical care and other issues. So I think that there needs to be a clearer distinction for people who are taking antipsychotics for FDA-indicated reasons versus not. That distinction, I think, needs to be made clear because, again, at Everett, we do have a very large percentage of our patients, who do have, one of these chronic psychiatric disorders are on antipsychotics, and, they need to be on them. You can try to do gradual dose reductions, and I've done gradual dose reductions, and it's, so sometimes the results, have not been good. People have, needed to be hospitalized because we've reduced their medications.
Regardless of the age, what are the factors that greatly affect everyone's mental health?
Yeah, I think for older adults and for younger adults, really so many things. I think certainly we talked about family before. I think being around family, having loved ones, feeling cared about, feeling loved, feeling understood, that's extremely important. Other factors, really that have been shown, and there are more and more studies, that are out there every month that are looking at things like exercise, being active, being physically active, walking, biking, weight training, things like that. You don't want to overexert yourself, but just, having some kind of physical activity. Keeping your brain active and healthy, doing word games and puzzles, but also just really being around people, going to events, going to parties, engaging in interest, engaging in activities that are interesting. Those are things. Eating well, and all these things again will help with cardiovascular risk factors, which are associated with increased risk of depression and cognitive disorders in older adults.
You are a very excellent psychiatrist. Working with you is really of experience, working with a great doctor like you. And what do you think what it takes to be a great psychiatrist like you?
Well, thank you. I appreciate that. Yeah, I think what's important, I think for any of us, not just for being a geriatric psychiatrist, but nursing, therapy, social work. I think it's just really caring about the patients, wanting to get to know them, wanting to understand them, having them know that that you sort of get what's going on. Really just truly listening, being empathic. My role model, I guess, as a psychiatrist, is Carl Rogers, who's a psychologist from the last century. And he talked a lot about being very empathic, listening, and just having what's called unconditional positive regard, just, really trying to, keep everyone in the best light possible, trying to understand where people are coming from, trying not to, be negative or pejorative, but just saying, yeah, this, given your experience, given what you've been through, I understand why you would react that way, or I understand why you'd be angry or frustrated. But I think also, being thoughtful, really paying attention to symptoms, and just making sure that you're treating things properly, making sure that things that don't require medications, you don't give them medications, and things that do, you want to make sure that people are not overtreated, but you certainly want to make sure that people are not undertreated as well.
So what are your advice to this population who always have negative perception about mental health?
Yeah. I think that hopefully this is a stigma that is wearing off in the younger generations. I mean, I think just, thinking about it, there's such a large percentage of the population that, experiences mental health issues, be it dementia in older adults, be it depression, be it anxiety. If we ourselves aren't experiencing it, you'd likely have family members, friends, colleagues, people that are, experiencing something. And these are people who are just like us, and, people who either, have had these symptoms be passed down from generation to generation, or people who have had difficult things happen in their lives. Really, it could be any of us. If almost anyone has certain experiences in their lives, I think that, they would react in a way that could lead to depression or anxiety or other forms of mental illness.
Thank you, Dr. Strauss, for all the knowledge and time you spent with us today. It was greatly appreciated.
Yes, thank you. Great to be here. I really appreciate it.
So the population of old and particularly elderly populations is increasing rapidly throughout the developed and developing world. This reflects improving health and social conditions and is cause for celebration. Most older people remain in good mental as well as physical health and continue to contribute to their families and to the society. This notwithstanding, some mental illnesses, such as the dementias, are particularly common in older population. Others differ in clinical features and or present particularly problems in management. Social difficulties, multiple physical problems, and sensory deficits are also common. Appropriate detections and management require specialist knowledge and skills as well as multidisciplinary collaboration. Priority needs to be given to this population with mental illnesses can cause a great deal of stress not only to older people themselves but also to their families. This is aggravated by changing family structures as well. There is also an increasing number of older people living alone. So therefore, as Dr. Strauss said, that family is very important to support these people with mental health issues. Appropriate interventions for the major mental illnesses of an older population can either treat them effectively or at least substantially improve the quality of the life of the patients and their families as well. Thank you so much, everyone. And again, this is Senior Matters.